In this lecture, we are going to discuss about model analysis. What is model analysis? Model analysis is study of dental cards which helps to study the occlusion and dentition of the patient and helps to analyze the severity and degree of malocclusion and helps in ultimate diagnosis and framing a treatment plan for that particular patient. It's nothing but it's complete evaluation of the patient's dentition and occlusion by seeing a study model. Now, when we are planning to do a model analysis, we have to obtain a good study model. What are the ideal requisites of this study model? The study model should be an exact replication of the dentition and its supporting structures. While securing the models from the patient, that is, while taking the impression and while pouring the cast, there should not be any distortion of the soft tissues. The exact anatomical structure should be recorded in the manner in which they are present in the patient's mouth, and the study models should be well finished and polished so that they can be preserved, and in the course of preservation they won't undergo any kind of changes like tarnish. When we take the study models, they have some advantages. Let us look into what are the advantages of study models. They are the three-dimensional representation of the patient's dentition and occlusion. Even in the absence of patient also, we can have them in hand. That means the patient's occlusion and dentition can be studied even in their absence. And one more thing is, we can also look into the lingual relationship of the maxillary and mandibular teeth. In the patient, we can't observe the relationship of the teeth from the lingual aspect, which can be done by using study models. And they serve as a permanent record for that particular patient during the entire course of the treatment, so that at the end of the treatment, we can compare the patient's dentition before and after the treatment. One more advantage of the study model is, with the help of the study model, we can explain the patient, we can motivate the patient, like what kind of abnormality is present in them and what is the necessary correction that is needed to be carried out in that particular patient. One more thing is, suppose we are transferring a patient from one clinic to another clinic, maybe due to a patient's problem or a clinician's problem. The second clinician who takes up the patient might not be knowing at what stage the patient's dentition was prior to the treatment. This secure study models will help as a record so that the clinician who newly takes up the case will also understand or will also have a clear idea about the pre-treatment status of the dentition and occlusion of that particular patient. So these are the important advantages of study models, and they can be used for treatment planning, and they can be used for post-treatment assessment of the clinician's skill. Suppose we have a set of study models before the treatment and we fix certain points in our mind which are to be achieved in this particular patient, and suppose at the end of the treatment we are not able to achieve these required parameters in the treated dentition, then we can assess by comparing it with the previous models where the mistake has gone and what kind of corrections in our treatment plan should be carried out in future, so that the required things can be easily achieved without missing. As the study models have several advantages, so also there are disadvantages. The main thing is, we have a certain number of analysis proposed by different authors. These model analysis were proposed based on their studies on a different group of population. Now, is it reliable to apply the model analysis uniformly for all the groups of population? That means the model analysis are based upon the studies on people from different ethnic group. Can the values drawn for a particular ethnic group can be applied, that is, can the normative values obtained for a particular group of population can be applied to another group of population? This is one of the drawbacks of study models. And the sexual dimorphism, that is, the normative values are not drawn separately for males and females. Okay, that means there is no differentiation between the males and females pertaining to the normative values that are obtained by various model analysis. The skeletal malrelationship of the patient is not taken into consideration during analyzing the study models. These are the important disadvantages of model analysis. One more disadvantage is we can't see the inclinations of the roots when we use a study model. So these are important disadvantages of study model, yet there are more advantages in drawing a diagnosis and a conclusive treatment plan, as study models are essential diagnostic aids. Remember, study models are one of the essential diagnostic aids. Despite of their disadvantages, yet they have much relationship to the clinical diagnosis and treatment planning. Now, coming to the model analysis that are available to evaluate the dentition and occlusion. So, the model analysis can be classified into analysis that are done in permanent dentition and those which are done in mixed dentition. Coming to the permanent dentition analysis, we have a Pond's analysis, Linder-Heath's analysis, Ashley-Ho's analysis, Bolton's analysis, CAREY'S analysis, arch perimeter analysis. Whereas, when coming to mixed dentition analysis, we have a Moyer's method, Tanaka-Johnston analysis, radiographic methods, and there are some more methods like Hukaba analysis and Hickson and Oldfather analysis. Apart from the analysis, we also have a photographic analysis of the study models like stereophotogrammetry, holographic image analysis, and occlusograms. And yet we have a computerized analytic techniques like OSCOPO and reflex metrography. So these are the different analysis that we can carry out on study models as well as their photographic counterparts. Before going into individual analysis, let me tell you something. There are two conceptions or two thoughts regarding the model analysis. Some authors say that a malocclusion will occur due to arch length and tooth size discrepancy, whereas some analysis say that the discrepancy is due to arch width and tooth material. See, different analysis will take different concepts. So few analysis will deal with, say that the discrepancy between tooth material and arch width is the main reason for underlying malocclusion, whereas the discrepancy between arch length and tooth material is the main reason behind malocclusion according to some. Let us discuss few analysis which support this concept and few analysis which support the other concept. The armamentarium which we require to do a study model analysis is divider, a ruler, plane, a wedge ruler, vernier calipers, brass wire. Let us discuss about permanent dentition analysis first. The first one will be Pond's analysis. This analysis is one of the supportive of arch width and tooth size discrepancy. In this analysis, what we do is we will estimate the width of the arch in the premolar and molar region based upon combined mesodistal widths of 4 maxillary incisors. Okay. So first we will measure the sum of incisors, that is mesodistal widths of maxillary incisors. Now we will measure the width of the arch in the premolar region taking from distal occlusal pit of first premolar on one side to the distal occlusal pit of first premolar on the other side. This is called as measured premolar value. Similarly, we will measure the arch width in the molar region from mesial occlusal pit of maxillary first molar to the mesial occlusal pit of maxillary first molar on the other side. This is called as measured molar value. Now, we will calculate the actual width that is supposed to be present in that patient based upon the combined mesodistal widths of permanent maxillary incisors. The formula given by the points are sum of the incisor into 100 by 80 for width of the arch in the premolar area, which we call as calculated premolar value. Similarly, we have a formula of sum of the incisors into 100 divided by 64, which gives the width of the arch that is supposed to be present in the maxillary arch in the molar region. This is called as calculated molar value. Now, we will compare the measured premolar value to the calculated premolar value, measured molar value to the calculated molar value. If the measured value is less than the calculated value, then it indicates that we need expansion of the arch. Okay. If the measured value is more than the calculated value, that means the width of the arch is already more than that it is supposed to be. So no need of expansion. So the Pond's analysis mainly gives an idea of whether we need to expand an arch or no need of expansion of the arch based upon calculation of the ideal values of the width of the arch based upon 4 maxillary incisors. This is Pond's analysis. Now, what are the drawbacks of Pond's analysis? As the Pond's analysis mainly relies on the width of the maxillary incisors. Sometimes, as we know, that maxillary lateral incisors are the most commonly missing teeth. So this analysis cannot be applied in cases of missing maxillary incisors. The next drawback is most commonly malformed teeth are maxillary lateral incisors again. So when we have a peg-shaped lateral incisors, we can't conclusively draw or we can't conclusively evaluate the exact width of the arch as per Pond's analysis. And this analysis was done on French population. Whether these normative standards can be applied to other population is questionable. And the skeletal mal relationship of the patient is not considered. Okay, these are the important aspects of Pond's analysis. The next important analysis is Linderhirth index. This analysis is same as Pond's analysis, but the only difference is the formula of width of the arch in the premolar region. In the Pond's analysis, it is sum of the incisors into 100 by 80, whereas in the Linderhirth's analysis, it is sum of the incisors into 100 by 85. That means the difference between Pond's and Linderhirth's analysis is Linderhirth says that the calculated premolar value is less than that calculated in the Pond's analysis. This is the only difference between Pond's and Linderhirth's index. Apart from this, both are the same. Even the calculated molar value in the Linderhirth's index is same as that in Pond's analysis. Okay. The next important analysis is Ashley-Howe's analysis. According to this analysis, crowding occurs mainly due to discrepancy between the tooth material and arch width. Howe says that there is a relationship between total tooth material mesial to the second molar and width of the arch in the region of premolar. So this is the analysis that says that the crowding in the dental arch occurs mainly due to discrepancy between tooth material mesial to the second molar and arch width in the region of premolar, first premolars. Now the procedure of the analysis is, first we need to measure the mesodistal widths of the teeth mesial to the second permanent molar. This is called as total tooth material, separately in the maxillary arch and mandibular arch. Now, next thing is we need to measure the basal arch length. The process is, we will draw a line which is tangent to the distal surfaces of maxillary first permanent molar in the maxillary arch and mandibular first permanent molar in the mandibular arch, and to this tangent we draw a perpendicular that passes through the midline Now we will measure the distance between this point on the midline of the tangent to the midline of the dentition. This gives the basal arch length. Now we will measure the width of the arch in the region of premolar from the cusp tip to the cusp tip. This is called as premolar diameter in the first premolar region. Next thing is we will measure the premolar basal arch width. This is measured in the portion of the gingival region, in the apical region of the first premolar. Premolar basal arch width is measured from the root apices of first premolar on one side of the arch to the first premolar on the other side of the arch. Now we will calculate the percentage of premolar diameter to the tooth material, percentage of premolar basal arch width to the tooth material, and percentage of basal arch length to the tooth material. If premolar basal arch width is more than premolar diameter, then it's an indication that the basal arch is sufficient to allow the expansion of premolars. If the premolar basal arch width is less than the premolar diameter, then it is an indication that the existent premolar basal arch width does not allow further expansion in the region of premolars. The second inference is, if the premolar diameter is greater than the premolar basal arch width, that indicates expansion is not possible, and rather we need to extract the teeth in order to correct the malocclusion. And the last inference is premolar arch width percentage. If the percentage of premolar basal arch width is less than 37%, that indicates we need to go for extraction treatment. Expansion is not possible. If premolar basal arch width is 44%, then the case is said to be an ideal case or a borderline case where we no need to go for extraction. Okay. Now, if the basal arch width is between 37 to 44%, it's a borderline case, and we may go for expansion or may not go for expansion. Okay. So if premolar basal arch width is less than 37%, we can't go for extraction, and we need to go for extraction of the teeth for treatment. If premolar basal arch width is 44%, then this is a strict indication of expansion. That means we can go for expansion and there is no need of extraction. That means absolutely we can go for extraction if premolar basal arch width is 44%. Absolutely we can go for expansion if the premolar basal arch width is 44%. If the premolar basal arch width is between 37 to 44%, this is a borderline case, and we can go either for extraction or expansion depending upon the patient's requirement. So this is about Ashley-Howe's analysis. The next important model analysis is Bolton's analysis. This analysis says that there is a proportionate relationship between maxillary to the mandibular dentition and vice versa. Any disproportion between this relationship will lead to malocclusion. Now let us see the procedure of Bolton's analysis. We need to measure the mesiodistal widths of the teeth which are present mesial to the second molar. That means first molar on one side of the arch to the first molar on the other side of the arch, both in the maxilla and mandible. We should calculate another measurement, that is mesiodistal widths of the 6 anterior teeth in the maxillary and mandibular arch. Now we should calculate two values. One is overall ratio and another one is anterior ratio. Overall ratio is the ratio of the mandibular 12 permanent teeth to the maxillary 12 permanent teeth. It should be 91.3%, which indicates a good proportionate relationship between maxillary and mandibular arch. Whereas anterior ratio is the ratio between mandibular 6 anteriors to the maxillary 6 anteriors, and it should be 77.2%. Any increase in the overall ratio more than 91.3% indicates that there is mandibular tooth material excess or maxillary tooth material deficiency. Similarly, if there is a more than 77.2% of anterior ratio, that indicates mandibular teeth are excess or maxillary anterior teeth are deficient. So accordingly, we should plan the treatment. If the mandibular tooth material is excess, then we can go for amount of excess that is present, and we can go for either proximal stripping or extraction, whichever is necessary. If the maxillary tooth is deficient, then we can go for composite buildups or any kind of mild, restructuring or recontouring of the teeth in the maxillary arch to fit or to establish a proportionate relationship between maxillary and mandibular dentition. That means a standardized ratio exists between the maxillary to the mandibular or mandibular to the maxillary tooth material. Any deviation in these standardized ratio will lead to a malocclusion, which may represent itself in the form of crowding or spacing or increased in the overjet. As usually for any model analysis, the major problem is not taking the skeletal relationship into consideration and not establishing a sexual dimorphism. These are also the drawbacks of Bolton's analysis. And one more thing is, these analyses were done on a separate group of population and their universal applicability is still questionable. We need to go for further studies on a specific group of population to see whether this analysis fits to that group of population or not. The next important analysis is arch perimeter analysis. This is nothing but CAREY'S analysis. CAREY'S analysis is done in the mandibular arch, whereas arch perimeter analysis is done in the maxillary arch. The terminology are different, but the basic method is same. So in the maxillary arch it is called as arch perimeter analysis, whereas in the mandibular arch it is called as CAREY'S analysis. Now let us look into the procedure. First, we should measure the length of the arch mesial to the first permanent molar, that is from second premolar on one side to the second premolar on other side. Next, we should measure the total tooth material mesial to the first permanent molar. That means combined mesodistal widths of the teeth extending from second premolar on one side to the second premolar on the other side is measured. Now, we should measure the difference between arch length and tooth material. If the tooth material is excess by 0 to 2.5 mm, then in order to relieve the crowding or in order to fit the teeth within the dental arch without any kind of crowding, we need to go for proximal stripping. If the tooth material is excess by 2.5 to 5 mm, then we can go for extraction of second premolars to fit the teeth within the dental arches or to accommodate the teeth in the existing arch length. If the tooth material is more than 5 mm excess when compared to the arch length, then we can go for extraction of first premolars to fit the teeth within the dental arches or within the available arch lengths. That means any model analysis is a space analysis that gives you an idea of the space requirement, whether it's excess or deficient with respect to fitting the teeth within the respective dental arches. Okay, it is not the total space analysis to treat the malocclusion. It is the analysis, the model analysis gives you only idea about the space requirement to fit the dentition in their respective dental arches in a coordinated manner. Okay, this you should keep in mind. As I told you, in CAREY'S analysis, we are going to measure the arch length from second premolar on one side to the second premolar on the other side by using a brass wire. The brass wire should extend along the buccal cusp tips of the posterior teeth and the canine cusp tip and incisal edges of the anterior teeth, provided that the inclinations of the teeth are normal. If the teeth are proclined, then the brass wire should be carried out along the cingulum of the anterior teeth in measuring the arch length. Similarly, if the anterior teeth are retroclined, then the brass wire should be passed slightly labeled to the labial surfaces of the anteriors when measuring the arch length. So these are the minor modifications that we do in CAREY'S analysis when measuring the arch length. But when there are abnormal inclinations of the anterior teeth. Okay. So those are the permanent dentition analysis that are most commonly used clinically and most commonly asked from the academic point of view and from the examination point of view. Now, the next important thing is mixed dentition analysis. As I told you, in the permanent dentition we have a full complement of permanent teeth and we need to just evaluate the arch length and tooth size discrepancy, or arch width and tooth size discrepancy, whatever it is. But when we take a mixed dentition, most probably we don't have full complement of teeth. Most commonly missing teeth, or most commonly unerupted teeth will be canine, first premolar and second premolar. Of course we can measure the arch length mesial to the first permanent molar, no issues, but we don't have a permanent teeth in the oral cavity to measure their width. So when we do a mixed dentition analysis, we will measure the arch length in the region of missing teeth, or arch length in the region of distressed dentition, and by some means we will evaluate the combined mesiodistal widths of unerupted permanent canine and premolars, and we will see the discrepancy between the unerupted tooth size and the available arch length to accommodate those unerupted teeth. So that is the importance of mixed dentition analysis. As I told you, there are different numbers of mixed dentition analysis, but the most important ones are Moyer's mixed dentition analysis and Tanaka-Johnston analysis. Let us look into the Moyer's mixed dentition analysis. In this analysis, we will find out the combined mesiodistal widths of unerupted canine and first and second premolars based upon combined mesiodistal widths of erupted 4 permanent incisors, both in maxilla as well as mandible. The process is, first we will calculate the sum of incisors, the 4 incisors, both in the maxilla and mandible separately. Now, we will have a Moyer's prediction table or probability chart. We will compare the sum of incisors with the 75% probability of occurrence of the combined mesiodistal widths of canine and premolars in the probability chart. That means at 75% probability in the prediction table, we will evaluate the combined mesiodistal widths of unerupted canine and first and second premolars. This is how we will estimate the width of the dimensions, the combined dimensions of the unerupted canine and first and second premolars, and we will compare the discrepancy between this obtained size of the teeth with the available arch length in the dental arches, and we will evaluate the space requirement, whether the space will be excess for those unerupted tooth or the space will be deficient for those unerupted tooth, and accordingly we will plan our treatment. This is about Moyer's mixed dentition analysis. Next important analysis of the mixed dentition is Tanaka and Johnston analysis. It's nothing but a simple formula. The predicted width of the maxillary canine and premolars, unerupted maxillary canine and premolars, is given by sum of mandibular incisors plus 11 by 2. Whereas the predicted width of the mandibular canine and premolars is given by sum of mandibular incisors plus 10.5 divided by 2. That means here we are taking the mesiodistal widths of combined mesiodistal widths of the mandibular incisors as a standard value. Based upon this value, by using specific formulae, we are estimating the combined mesiodistal widths of unerupted canine and first and second premolars. So this is about Tanaka and Johnston analysis. So these are different kinds of model analysis that we use clinically to assess the discrepancy between arch size and tooth material size. So depending upon the patient's necessity, we need to go for specific kinds of model analysis to predict or to infer what is the discrepancy that is occurring, whether it's a tooth size and tooth length and tooth material and arch length discrepancy, or tooth material or arch width discrepancy. That is major reason behind the existing malocclusion should be drawn, and accordingly we should formulate our treatment plan. Okay, thank you.